Right, hello everybody. Just a sound check, can you hear me?
Yes.
Good. Welcome to the monthly meeting of the governing body of Norfolk and Waveney CCG. Obviously, we are holding this meeting in public, a bit different from what we'd normally have, but in the light of coronavirus, we're trying to make this as accessible as possible to the public. So I think we are being helped by Tim today to stream this. I think we're being live streamed with this meeting, and hopefully you received the minutes or the documents that came out last week for this governing body meeting, and you've got them in front of you. The meeting obviously starts now. We're planning to finish by 3:30, and we do need to stick to time because we have got people coming for their items, and so please can you make sure that you stick to your times. So we'll do item one. I haven't had any actions to take under chair's actions. Item two is for apologies, and we've had apologies from John Ingham, the finance director, but Jason Hollidge is deputising and he's present today. We've also had Alex Stewart, who is an observer to this meeting, who can't attend, but Judith Bell is here deputising for him. So welcome, Judith. In addition, although they're not members of the governing body, we do have members in attendance. In particular, I'd like to welcome Mark, Catherine, and Howard as the locality directors. So welcome to them. And I think that's all the apologies and members. Was there anybody else, Melanie? I'm looking to you that I've missed. No, okay. So item three is declarations of interest. So just firstly a reminder: the register of interests is published and available, but it's important that it's kept up to date. So just a reminder for that, and also if there are any items where there may be or is an interest, please can you either let me know now or during the item, if you can make me aware that there may be or conflict of interest. So just a reminder for that. Additionally, although it's not separately itemised, we do give an opportunity for members of the public to ask questions when we meet in public. And we have had a question which was sent to us prior to the meeting, which I think Tim is putting up on the screen. And it was in relation to access to doctors' surgeries for people learning with hearing difficulties and deafness. In particular, the issues created by coronavirus, where access has been restricted. So you've got the question in front of you there. We do intend to deal with the question, to answer it fully online, and I'm going to ask that when we have the item, which I think is item 10, our response to COVID, that we cover the answer to that question in more detail then. So we'll deal with that later in the agenda. Okay, so on to item 4, which is to approve the minutes of the last meeting which we held, which I'll just bring up in front of me. So that's the meeting that was in the June meeting, wasn't it?
Chair, that was the meeting from May, 19th of May.
Yes, it's the May meeting. Yeah, I'm just getting it in front of me. My technology isn't working that well. So are there any items of accuracy on those minutes of that meeting that we held in May? I'll take the whole document as a whole, actually. So are there any items of accuracy? No. Okay. I think if there are, if people want to make a comment, obviously if you can use the chat box if you want to make yourself known to me, if you want to make a comment during any of the items, use the chat box to make me aware that you want to talk. Failing that, if you're on video, you can wave at me and I'll try and notice that as well and let you contribute, but I'm not noticing anything on that accuracy item. And are there any matters arising from that meeting in May, which we're not covering on the agenda today? No, okay. Well, I'm sticking to the rules and running slightly ahead of time, which is good. So we're on item 5, which is the action log, and I don't think there's anything that's due on the action log today. Let me just have another look. Yeah, so the governance handbook isn't due until September, and the financial plan coming to the governing body, that's in progress, but we're not expecting that today, although we have got a financial report today. Karen, is there any update on that action 2 on the governance handbook? Is that still on track for September?
Yes, that is on track. The review's being worked through at the moment.
Okay, great, thank you. So on to item 6 then, which is one of the main sections of the meeting today, focusing on equality and diversity. So we've got a few items on this section, and I'm going to ask Melanie to open up the discussion on this. So Melanie, over to you.
Thank you, Chair. It's a privilege to open up this section on the governing body agenda. I'm delighted and pleased that the governing body is focusing its attention on this very, very important matter today. And I'm sure we've all been living through such difficult times recently and will have noticed the way the pandemic has revealed and exposed even deeper inequalities in the world that we're living in. And it's made me feel incredibly sad, incredibly angry. And I've kept it in my mind during all of the conversations and society discussions around racism and inequality and different opportunity. I've kept in my mind my friends, my family members who are from Black, Asian, minority ethnic groups. I've kept in my mind my colleagues that I work with now and my colleagues that I've worked with in the past. And I've kept in my mind those healthcare professionals who are from Black, Asian, minority ethnic communities who have looked after me when I've needed their care. And this is a very, very important topic for us to make a difference, and we can make a difference as a big employer and as a healthcare provider in Norfolk and Waveney. We can change people's experience and health outcomes through the services we commission by listening to people from Black and Asian and all those very different minority ethnic backgrounds who will all need different approaches to receive the best possible care that's appropriate for them. And we need to listen to them as an employer. And we can make a difference as well for the staff working within the NHS in Norfolk and Waveney. We are one of the biggest employers in Norfolk and Waveney. And we have, although proportionately compared to other parts of the country, we have a lower percentage of staff from Black, Asian and minority ethnic background. We have a sizable community and they provide an important care for our population. And how we look after our staff from those communities sets the tone and can change how we regard racism and how we value those communities. Racism has no place in the NHS or indeed in Norfolk and Waveney. And this section today is to highlight the changes that we can make and we want to make, and the action. It's not just about having a commitment, but it's actually about taking action that will lead to change. So I'm I think that we're going to start this section by playing a small clip, and then I'm going to hand over to Anna Morgan, who is our Director of Workforce for the Norfolk and Waveney Health and Care Partnership.
So, it's finally happened.
That thing you were afraid of.
Something's come from overseas
and taken your jobs.
Made it unsafe to walk the streets.
Kept you trapped in your home.
A dirty disease.
Your proud nation gone.
But not me.
Or me.
Or me.
Or me.
No, you clap for me now.
You cheer as I toil.
Bringing food to your family.
Bringing food from your soil.
Propping up your hospitals.
Not some foreign invader.
And the very driver.
Teacher.
Lifesaver.
Don't say go home.
Don't say not here.
You know how it feels for home to be a prison.
You know how it feels to live in fear.
So you clap for me now. All this love you are bringing.
But don't forget when it's no longer quiet.
Don't forget when you can no longer hear the birds singing.
Or see clearer waters.
That I cross for you.
To make lives filled with peace.
And bring peace to your life too.
Come, all you Gretas.
You Malalas.
You immigrants.
See what we have learned.
It only takes the smallest thing
To change the world.
Hello everyone, I'm Anna Morgan. As Melanie said, I'm Director of Workforce for the Health and Care Partnership, and I'm also taking a lead role on equality and diversity and inclusion. And I'm now going to try and share my presentation. Has it come up?
Yeah.
Great. Okay, so equality, diversity and inclusion is about treating people equally and fairly and respectfully, and celebrating difference as a part of our fully participative society. Both myself and Claire have got quite a number of slides, so please forgive us if we skip through them quickly because there's a lot to get through. I'm not going to read everything on the slides, but it'll just give you a flavour of what's happening nationally and locally. So equality, diversity and inclusion are different things, and they do need to be progressed together. Recent publications have highlighted the need for us to really understand our shortcomings and to champion equality, diversity and inclusion. This is our leadership responsibility, and we need to take action on the inequalities that have been highlighted by COVID and take action on the discrimination and abuse that's experienced in our society and our workplaces. So since 2011, the NHS has had an equality and delivery system in place, and this system sets really clear standards on how we can improve the services that we provide for our local communities and create better working environments. And these are set out in four goals. There are 5 outcomes. So every year we take a score on this system and we look at where we can improve. And this year, these are the 5 outcomes that we have highlighted that are our areas of focus where we want to make improvements. So we have a responsibility to safeguard our vulnerable people and our at-risk staff, and we're required to carry out risk assessments for all of our staff and take action on the findings, and this is being reported nationally. Claire is going to go into a bit more detail now on the outcomes from, or what we've learned actually as a result of COVID, and then I'll come back to our local response. So I'm just going to hand over to Claire now. Claire, are you there?
Are you muted, Claire, by any chance?
Apologies, Chair. Thank you, Anna. Good afternoon, everybody. My name is Claire Hambling. I'm one of the local GPs, governing body GP. I have a particular interest in diabetes and population health management, but like many people here, driven to try and reduce healthcare inequalities across the system. Much of my presentation this afternoon comes from a publication by the South Asian Health Foundation. Many of the academics that are involved in this publication are colleagues and indeed dear friends of mine. It's a publication that I would highly recommend to anyone who would be interested in reading further, and I've given you the link here on the slides. Thank you, Anna. If I could have the next slide, please. The review draws on multiple sources of data, much from the scientific press, but also data from Public Health England and the Office of National Statistics, and multiple other sources of what we might describe as grey data. One thing that's outstanding from all the evidence when taken together is it really does highlight the marked ethnic inequalities in terms of the risk of outcomes from COVID-19, particularly around hospitalisation rates and mortality. Although there are some differences between studies, it's quite clear that amongst Black, South Asian and other minority ethnic groups, there's quite marked variation, but nonetheless the data is consistent, and particularly for people from Black ethnicity, where the risk of mortality from COVID-19 may be as much as doubled compared to white populations. Next slide, please. There are also two other important studies that I'd like to draw your attention to, and these were undertaken by NHS England and looked at the data from almost the whole of the population of England, so a huge data set involving 62 million people. Thank you, Anna. One of the reasons that the concern regarding ethnicity or mortality first came to light was charted from some of the work with the diabetes team in NHS England. And what I've shown here is the weekly mortality rate for people with type 2 diabetes, which dates from January 2017. And you can see that when we hit March of this year, there was an exponential rise in the weekly mortality rate amongst people with diabetes, to almost doubling the normal background rate, or in fact, I think slightly over double the background rate. Thank you, Anna. So this led to quite significant further investigative work to find out why might this be and what were the factors that seemed to predispose to that risk. And as many of you will know from the media, perhaps the single most important risk factor for poor outcomes with COVID-19 is age. But what you can see on this slide, if you look at the black line along the bottom, it looks at age in the general population. The blue line looks at mortality by age in people who've got type 2 diabetes, and the red line the same in people who've got type 1 diabetes. And you can see from this graph that there's a significant increased mortality in people both with type 1 and type 2 diabetes. And you can also see that that risk of mortality seems to start at a much younger age compared to the background population. So a significant concern highlighted there. Next slide, please. Can I have the next slide? Oh, lovely. With the infographic. Thank you. This is a really nice infographic from the South Asian Health Foundation, and what it shows here are some of the factors that have been associated with increased mortality in COVID-19. If you look at the items in green, they're the things for which there's fairly strong evidence base now. The yellow items where there may be emerging evidence, the blue items where there's some limited evidence, and the red areas that are not yet known but are hypothesized. And if you look at the green items, you will see there that we have age, we have gender, so unfortunately men are affected more than women. And then we have a number of important metrics. So, for example, people who are who struggle with weight management and obesity, people from more deprived backgrounds, and people who live with comorbidities, so other conditions, including particular heart failure and people who've had strokes and people who have got diabetes. But importantly, ethnicity is an independent risk factor here. Thank you. The South Asian Health Foundation has explored why this might be, and they've described three important parameters, what they describe as structural inequality, biological factors, and behavioural factors. In fact, I think their choice of wording around what they describe as structural inequality is very soft and gentle. I think this is what many of us would recognise as systemic discrimination or systemic racism. And it applies to lots of factors, but including such as housing or occupation, income, education, and access to healthcare. And across all these areas, there's evidence that people from Black, Asian, and minority ethnic backgrounds suffer discrimination compared to white populations. In terms of mortality in COVID-19, it's possible that there are biological factors that contribute. So some hypothesis around vitamin D status, which I think is not yet proven by any stretch of the imagination. But also people from Black, Asian, and minority ethnic backgrounds have an increased risk of what we describe as cardiometabolic disease. So particularly diseases affecting the heart, stroke, a tendency to be overweight or obesity, and type 2 diabetes. And those themselves increase the risk for adverse outcomes with COVID-19. Interestingly, there was also a description of what was described as behavioural factors. And I felt I learned a lot from reading this. So a few things here that I hadn't really thought about before. So some of it are things that we might well appreciate. For example, information, access to information around COVID-19. If it's not available in the language that you understand, that's obviously going to be more difficult for you. But some cultural factors, such as fatalistic beliefs, or perhaps the dilemma you may face if you're asked to use an alcohol-based hand gel, and that is culturally difficult for you. Thank you, Anna. Occupation, Anna has already alluded to. So as well as doctors and nurses working in the healthcare and other disciplines within healthcare, people from Black, Asian, and minority ethnic backgrounds are more likely to work as social care workers, healthcare assistants, hospital cleaners, and in transport and delivery, taxi drivers and security guards and other such jobs. As key workers, they were all likely to have been, or more likely to have been, exposed during the course of the pandemic, and that may have contributed to the prevalence amongst Black, Asian, and minority ethnic backgrounds. Importantly, though, many of these roles are roles associated with 0 hours contracts and lower pay. So again, we can see yet again the interplay here with the social determinants of health that contribute to risk of adverse outcomes in health in general, actually, but particularly with COVID-19. Thank you, Anna. When we look specifically at outcomes amongst healthcare workers, across the NHS as a whole, approximately 21% of staff are from Black, Asian, or minority ethnic backgrounds. Shockingly, though, when you look at the mortality from COVID-19 amongst healthcare workers, 76% of healthcare workers who succumbed to COVID-19 were from Black, Asian, or minority ethnic backgrounds. And I think that really hit home for me just what the excess risk was here, and really quite alarming. Thank you. Another study that I was really quite shocked by was some evidence from the Royal College of Nursing, who undertook a survey of their members around the access to PPE. And you can see here that there was significant difference in reporting of sufficient levels of PPE in white compared to Black, Asian and minority ethnic nurses. And furthermore, nurses from Black, Asian and minority ethnic backgrounds more commonly reported being asked to reuse PPE that was designed for one use only. And I was really quite shocked by this. Now, some people would say that we have to interpret the results of surveys with caution from a scientific point of view, but I would argue that often a survey allows someone who feels they lack voice an opportunity to say something which they at other times might be reluctant to raise as a concern. And I think it's important that we recognise that with the results of this survey. Thank you. The report then goes on to make a number of recommendations, and they break these down into 3 sections. So the first is on immediate actions or things that could be done quite quickly that might make a difference. So the tailored messages, and interestingly, there was some information on the news today about the lack of access to culturally and language appropriate messages. So I think that's again highlighted here. The longer term actions on the next slide, which really address many of the social determinants of health, but also consider some of the concerns that we have in the NHS. And then on the next slide. And then culturally specific recommendations, which I think we need to be particularly sensitive around. Thank you. In terms of what we're doing locally, Anna has already referenced much of what we're doing in the NHS, and there are a number of things that we are encouraging, particularly around occupational risk assessment, and some things that we're doing in terms of clinical aspects. So within a diabetes project that we're developing, recording ethnicity has been highlighted as something that we need to do better on that, and we're taking steps to do that. And just for the sake of time, I think I'll hand back to Anna. Thank you.
Thanks, Claire. So what are we doing locally? As I mentioned, we're rolling out the risk assessment process across all of the organisations, including primary care and the CCG. Our human resource directors across both the health organisations and social care are meeting every 2 weeks, and the risk assessment process for our BAME and vulnerable staff has been absolutely at the top of their agenda since we started to hear information about how COVID was affecting our staff. We have a national requirement to complete all of the risk assessments by the 31st of July, so that's this week. And we're also reviewing all of the outcomes from those risk assessments to see what we actually need to do to make changes for our staff, both now and in the future. So they're a very sort of strong group across our system and providing really, really good leadership. We also have the national team that are coming to meet with us on a regular basis and help to provide us with leadership on this whole topic. So we also are developing our system oversight and governance. We will have our workforce strategy that we're calling We Care Together, our version of the People Plan. That is being launched in August. It's just out for print at the moment. And this has been developed following extensive consultation with our staff over a year. We would have launched this earlier on this year, but of course COVID did stop everything in its tracks. It's given us a fantastic opportunity, though, to really look at the learning from COVID, and particularly to think more about what we want to do in terms of inclusion and to be more aspirational. We're really sort of lucky to be working with Roger Klein. Roger Klein is a research fellow at the Middlesex University, and he is the author of papers such as Snowy White Peaks and Fairness at Work. And he's really helping us to really understand what we can do here in Norfolk and Waveney to be as inclusive as possible. I'm also really fortunate that I've been invited to join the East of England BAME reference group. So that means that I can bring national and regional best practice into our system really quickly. And I'll be working with inclusion leads to develop an inclusion network here in Norfolk and Waveney. So one of the things that Roger Klein sort of advised us to do was to really understand our workforce race equality and our disability data, so that we really understand what our issues here and what are our issues here in Norfolk and Waveney, but also to take into account some of the feedback from staff surveys, from our Freedom to Speak Up cases, our gender pay gap report, so that we can make sure that we're tailoring our approach as appropriately as possible. One of the things that themes that has come through as a result of the work that we've been doing with our staff is really about the lack of ambition that we have here in Norfolk and Waveney. So that's definitely one of our aspirational aims in our strategy, how we attract, recruit, and make sure that we're accelerating development for people, and particularly to raise the profile of our BAME leaders in our system. We'll also be using our staff's lived experience to really help us to shape our plan. And here you can see there's a list of actions in our strategy. I just wanted to mention that each year we have to we undertake this RES data collection, and this year, sorry. So this gives you an understanding of the indicators that we're looking at. The indicators that are highlighted in black, 5, 6, 7, and 8 are the indicators that we won't be collecting this year because of COVID, and we'll be focusing on the other indicators this year, but we would normally collect all of this data. We're working with all of the other organisations across our system to understand what their data collection is also telling us. So we ran a photo campaign this year, sort of halfway through COVID, and we're continuing to run this for some months to come. And in response to what happened with the murder of George Floyd, we ran a particular focus on Black Lives Matters. We have some amazing staff across Norfolk and Waveney, across our health and care system, and they've been telling their stories as part of this photo campaign. And I think Dr. Wirima, our respiratory registrar at the James Paget, really does highlight the issues beautifully for us. All of our staff that got involved in the photo campaign for Black Lives Matters have volunteered to help us to understand more about their experience in Norfolk and Waveney, which in turn will help us to make sure that we're shaping our responses not only to COVID, but what we want to achieve around equality, diversity and inclusion for people in our system. So I'll stop there, and apologies for the clumsiness over the slides, but I'm multitasking here and it proved much more challenging than I thought. So thank you, I'll stop there.
Great, thanks very much for that, and I don't think you need to apologise. I think you gave a very powerful and strong presentation. I want to just thank Melanie for the introduction, which I think was really heartfelt and really made me think. And then that video, I think, really was very powerful. And thanks for Claire and Anna for that presentation. We've got a few minutes for comments, and so use the chat box. So Rob, I think you want to ask a question or make a comment?
Yes, thank you very much indeed, Chair. Can I also just say that I found Melanie's introduction very, very powerful. Thank you, Melanie. And indeed the presentation very, very interesting. There's lots of interesting information that contained. We heard about some of the actions that we're taking. I'd find it very helpful to have a report back to governing body at some point in the future on progress against those actions, and also on the impact that they're having, because this is such an important area for us. Thank you.
Yep. So I think we'll make sure we bring a report forward on actions. That's a good point, Rob. Are there any other comments or questions people want to raise at this stage on what you've heard? Yep, Claire, do you want to make a comment?
I was just going to add that I understand that NHS England today has announced direct access to the risk stratification tool on Diabetes UK, which looks at risk of diabetes, which is one of those areas, as you know, that people from Black, Asian and minority ethnic backgrounds are particularly predisposed to. I believe my understanding was that one of the reasons that they have done that is actually to improve accessibility for people from Black, Asian and minority ethnic backgrounds. So the idea will be that if you undertake the risk on the Diabetes UK website and your risk is considered elevated, you will then be able to self-refer into the National Diabetes Prevention Programme. I think that announcement was only made earlier today.
Okay, no, thanks for bringing that to our attention. Great. Any other comments or questions? Yeah, okay. Well, again, thanks particularly to Claire and Anna for that presentation. The next item is item 8, which is kind of related actually, and you'll see from the paperwork that we're asking for you to approve and the appointment of a Freedom to Speak guardian, which is part of a national initiative which came out of Robert France's report, the Freedom to Speak Up review, which created a national guardian for speaking up, but it also requires and recommends organisations within the NHS to have guardians who are accessible to staff to be able to raise concerns where either previously they've not had the opportunity or the channel or the freedom within their organisation, perhaps because of the culture of the organisation, to have a person that they know they can go to who is independent and has got access to provide support directly or outside of the organisation. And I think some of the figures that Claire produced earlier shows that there are inequalities, including in terms of people with diversity and ethnic minorities, and those would be some examples where a Speak Up guardian is someone that they could go to who otherwise they might feel constrained within their own organisation to know who to turn to. So what within our CCG, Doris Jameson has agreed, and I was really grateful for her to step up and agree to be our Freedom to Speak Up guardian for the CCG. So I'd like your approval for her to take up that position. And also as part of this item, we're asking you to approve the attached document that was sent with the papers, which is a whistleblowing policy, which has been updated and adapted to make it fit for purpose for our organisation. So I'll take any comments from anybody first, if you like, and then I'd like your approval. Are there any comments people want to make, or any? And Doris, I don't know whether you want to say anything at all in terms of the role.
Yes, I mean, I would be delighted to support the CCG in this work. But I would ask you all to bear with me because the national organisation training is obviously affected by COVID as well. I had an email back from them about a week ago to say they will respond within 20 days. So training might be a bit slow, but I hope to be able to support the CCG and the wider system in the work.
Okay, great. Well, I think I'd like to then ask the governing body. Melanie, were you trying to say something there? No, I'm just sighing. So I'd like to ask then the governing body to approve for Doris Jameson to be our Speak Up Guardian. I'm really grateful for her actually for her stepping up to this. And yes, we will be very patient in our expectations, particularly with training, I think, in the current environment. So can I first ask you then to approve? Yeah, well, you can nod if you like, because I can see you all. Yep. So that's universal. And then to approve the document on whistleblowing policy. Can I ask you to approve the policy that's been drafted for you? Yeah. Okay. So we've approved that as well. So thank you for that. And I think that was a really important section for today. And again, thanks for those speakers. We're going to move on to the next section, which is the clinical commissioning section, which starts off bang on time. Actually, we're doing well. Thanks, Tim, for those reminders, by the way. So we're going to start with Melanie for the Chief Officer's update. Thanks, Melanie.
Thank you, Chairman. I've provided an update for members of the governing body, which really reports on the activities that I've been undertaking since the governing body last met, and also the focus of the organisation over the past couple of months. And I just wanted to highlight some of the sections that I've included in my report, and to start off by again really thanking all of our frontline staff in health and care sector who continue to take incredibly brave and selfless action during the pandemic. We are still needing to take extreme precautions, and personal safety is very in people's minds. And I'm incredibly grateful for all that everybody is doing and continues to do so. And of course, as the pandemic goes on into the months now, people are very tired and exhausted and are continuing to work incredibly hard. I wanted to, on that, just of course, to everyone will be aware, I'm sure, that the NHS remains in a level 4 national incident. There has been, I think, some understandable confusion about levels. We have 5 levels of COVID, which is a new national barometer around in relation to the risk that COVID-19 poses to the population. And we're at level 3 in that risk. It's of course been reduced, and that's completely separate to the risk level that the NHS is operating under. Level 4 incident relates to the fact that this is a serious incident. It's under the Civil Contingencies Act and allows NHS England to take control of local resources. And we remain, as we have been since the incident was called, in level 4. And so there remains considerable burden, understandably, and a changed focus for all staff in the health and care sector. And I again wanted to repeat my huge thanks to governing body members for the patience that they're showing and support as we continue to manage our normal business as best that we can, but also manage the pandemic. I wanted to also just mention 2 other points on the report. One was I was delighted again to read how well our general practices have performed as they normally do, but it continues to improve. We have exceptionally high quality general practice in Norfolk and Waveney, and the results of the GP patient survey were published a few weeks ago. Norfolk and Waveney GP practices overall performed very strongly compared to the national average. Of course, the survey was conducted before COVID, and there have been so many changes during COVID, changes to the way people can make appointments and are treated. And some of the areas where perhaps some surgeries particularly might need to rethink their approaches. Of course, actually, since the survey was conducted, and it's a national survey, of course, changes will have been made anyway. So it'll be very interesting to repeat the survey based on how general practice is currently operating. And of course, not all of our practices performed in the same way. And the CCG teams and staff will be working with practices to help them make the improvements and listen to their populations about what they need. And to finish, I wanted to just mention mental health and our financial investment in mental health. We have a mental health investment standard, which we are required and would want to make. It's an important, increasing need in our population, and we're seeing that deepen further during COVID. We are planning for the period of 2021 to meet the mental health investment standard, which is a requirement across Norfolk and Waveney. And I'm delighted we are investing a much needed additional £7.4 million in adult mental health services and a much needed additional 1.1 million in children and young people's services. Not only that, we have received national funding that we have bid for, which brings more money into Norfolk and Waveney for very important work around schools. And I'm delighted that we have secured additional funding for teams of specialist workers who can support children and young people across 20 additional schools based in the Lowestoft area and in South Norfolk. And this, of course, follows the pilots and the teams that we've already had in Kings Lynn and North Norfolk. So there's additional funding there, which will be much needed as we move forward and the schools start to reopen in September. We, of course, have met our mental health investment standard for 1920 as well across all 5 CCGs, and there'll be a further report on that to follow. So that was all I wanted to pull out, Chair, and happy to take questions on anything else.
Okay, great. Thanks very much, Melanie, for that excellent report. And I'll take any comments or questions on Melanie's report. I mean, I will just comment that Melanie made reference to the kind of the efforts that staff and particularly healthcare professionals have made in the COVID challenge. I mean, I just wanted to acknowledge and thank the CCG management team and all the staff that work within the CCG. You know, what I've observed is that you know, it's been a huge challenge for everybody, but they've worked tirelessly in situations which have been really stressful, dealing with situations well outside their comfort zone, and actually, you know, taking personal risk at times and doing deliveries for personal protective equipment to surgeries, for example. That they volunteered to ring patients as part of our COVID Protect when we didn't have anybody else to turn to. So I really wanted to personally thank Melanie and her team and all the staff of the CCG for really stepping up to the plate in recent months in really extraordinarily stressful and unprecedented times. So I wanted to say that. Claire, did you want to make a comment?
I'd like to echo that actually, and I've been very aware of just how hard everyone has worked, particularly just in the numbers of hours, the times of the day where people have been turning up for meetings and things like that. I think a lot of the frontline healthcare workers, doctors and nurses have been very well acknowledged by the public. But I think behind the scenes teams and other people that work in healthcare, which I'm not sure the general public necessarily always appreciate, are there, but the vital role that they have done during the course of the pandemic. So just to echo what you're saying, and thank you very much, everybody.
Thank you, Claire and Anoop, very much.
Okay. Great. Well, thanks for that and for that report. We're going to move on to then item 10, which is the report on the CCG's response to COVID-19. And I think, Kath, you're going to deal with that and to talk us through. And if you can, there was that question at the beginning around how COVID has affected the access to services for patients and the public who are deaf or have hearing difficulties. So if you could deal with that question as well, Kath.
Absolutely. Can you hear me?
Yes, I can hear you.
Thank you. There's a set of slides. I think, Tim, you're going to be the driver of the slides for us, aren't you? Thank you very much. So I'm going to take us through what is mostly a very data slide set, but annotate accordingly throughout the presentation, and aim to get through this quite quickly so that it gives opportunity for any discussion or any questions. So if we go straight into it. So this slide and the next slide show the number of laboratory confirmed cases in both Norfolk and the whole of Suffolk. And what you'll see in the data in the narrative at the bottom shows that in both counties, Norfolk and Suffolk have had lower cases than the regional and national average. Next slide, please. And again, please. So in terms of outbreaks, so this certainly from a CCG perspective, system perspective, and me personally, has care homes has been a significant part of my role. And we've got 397 care homes across Norfolk and Waveney. Some may cater for people in the older age range, but some also for people living with learning disabilities that require a care home setting. And what we have is that we know that in Norfolk, across the east of England, Norfolk has had the lowest number of outbreaks amongst the care homes in our county, and it's really pleasing to see that low number of outbreaks. And just to note, that isn't just taken into account if a patient or resident has a COVID positive test result, it could also be the staff as well. Now, Suffolk has had a higher level of outbreaks within the care home setting. We are only able to see data based upon the district council footprint. So East Suffolk has had a much higher number of outbreaks, although Waveney is a subset of East Suffolk. And doing a more manual check, the numbers in Waveney equate to around 40%, as opposed to the higher number of 60% across the whole of the district council footprint. Next slide, please. So in terms of registered, ONS registered deaths, bringing this slide to life a little bit, and apologies for people who may not be able to differentiate the colours. What the slide is saying in Norfolk is the numbers of deaths, both COVID related and non-COVID related, are lower than the expected number of deaths based on a 5-year average. And the same applies on the next slide to Suffolk, well, slightly higher in Suffolk, but very minimally so. Next slide, please. There's some data in relation to number of deaths, and you'll see 421 COVID-related deaths in the Norfolk 3 acute hospitals. Next slide, please. And in terms of deaths in care homes, so you'll see towards the bottom of this slide, 151 COVID-related deaths in the Norfolk care home setting accounts for 20.4 of the total deaths in care home, which is lower considerably than the national rate of 31.1, so about a third less than the national level, which is really positive. Next slide, please. And in Suffolk, the number is higher, 26.1, but again, still lower than the national rate. Next slide, please. You'll see the big spike on the screen in relation to people with a COVID positive diagnosis, test results who were in acute hospitals, and you'll see the peak in relation to that was end of March, beginning of April. And you can see now the most available data, middle of July, it's negligible numbers of people actually in hospital with a COVID positive status. Next slide, please. So this is a really interesting slide in relation to ED, A&E attendances and an acknowledgement of performance. So you'll see the numbers of A&E attendances drop significantly again towards the very end of March and throughout April, much lower rates than we would typically have seen at this time. But you'll also see the numbers of people now attending ED are not far off what they were in the pre-COVID status. Next slide. So in terms of bed occupancy, we still have a much lower occupancy rate than we might have expected had we not experienced COVID, but that will also relate to the fact that a much lower level of planned care, surgeries, etc. happening but also the need to create COVID secure areas with much greater spaces between the beds within hospitals. Next slide, please. Length of stay has been one of the positive improvements that we've seen within COVID. So we did see a significant drop in length of stay during April. It's gone up, but nowhere near the length of stay that we saw pre-COVID times. And we've done and we are continuing to do a considerable piece of work in relation to hospital discharge and improved flow through the hospital and more appropriate settings on discharge in a more timely manner. Next slide, please. So PPE has been a real tale of different experiences throughout the COVID period, and we will all know of the significant problems that we've had. We experienced towards the beginning when, whether it's the acute hospitals, the community providers, our care homes, our domiciliary care, our GP practice, we're all really struggling to access PPE because of the just worldwide demand for the products. And so we recognise this challenge and the level of anxiety, and we've heard also earlier on about about people on the front line being concerned about being exposed without necessary PPE. And the CCG really took arms in relation to this and identified a team of people to basically order huge amounts of PPE and ensure it's distributed to the GP practices across Norfolk and Waveney, to some care homes, to our patients who are cared for in their own homes where their carers required PPE. And it's been really remarkable, the response that's been had. And even last week, our team here in Lakeside received some cakes from a local GP practice in thanks for all of the support they were given in relation to supply and PPE, and just taking that pressure away from the frontline staff. And we're going to continue to do that. I would like, can you just go back, please, Tim? I won't say where it is, but we still have significant stocks of PPE. So therefore, we are still preparing for a continued challenge in accessing PPE to make sure our staff are protected. And then in terms of testing, again, I think this has been one of our really positive news stories in relation to COVID, and it's been a credit to both the laboratory at the Norfolk and Norwich Hospital, but also our community trusts who've provided much of the community-based testing, and staff deployed from lots of organisations to support that. We've done huge numbers of tests, antigen tests, which is for people to see whether they have the virus, and also progressing the antibody tests that are being made available. And we also now have a national testing site that's been put in the Poswick Park and Ride, and they have conducted over 18,000 tests to see whether people are COVID positive. Next slide, please. In terms of our workforce, the Norfolk and Waveney STP footprint Health and Care Partnership has had the best, highest number of staff, the bring back staff that's within the whole of the Eastern region. And as a result of this, Anna's team were invited to meet with the Prime Minister's implementation unit to find out why we were so successful in not just generating that interest, but making it actually happen in reality. So great credit to that team as well. Next slide, please. And finally, this is to say that both the local outbreak control plans for Norfolk and Suffolk have been published. We are full participants in outbreak control planning groups in both of the counties, and it's again a continuation of the way in which we've seen extraordinary system collaboration and working in partnership throughout the COVID period, and this will continue in the ongoing management of outbreaks, and I would say with it across health and care and wider going forward. And that will, I believe, be the legacy that COVID will have left us, is the way in which we are all very focused on supporting each other as a system with our population at heart. I'll stop there, Chair, and take any questions.
Okay, great. Thanks very much for that, Kath. Any questions for Kath? Any comments on her report? Yep, Rob, would you like to make a comment?
Thank you very much, Chair. Thank you for the presentation, very, very helpful. I was just interested in the A&E attendances and the fact that those have drifted back up to pre-COVID levels. I can understand why during the crisis, peak of the crisis, people didn't want to go to hospital and attend A&E, but I think it might be helpful if we could understand what was happening in that period, because people may have been accessing other services, and looking to the future, that might be a way of trying to manage the number of attendances in A&E going forward.
Absolutely, and it was actually really fascinating week on week as we were seeing these numbers and considering the why. And I think there's probably a way of categorising urgent and emergency care access, or reductions or increases in so. So you might anticipate that there is a group of our population who you would expect actually wouldn't be attending ED, for example, or other urgent emergency care settings, because we were all in lockdown, so that the kids weren't having accidents in school, there wasn't contact sports underway, there was far less cars on the road, etc., etc. So actually the cause of the demand pretty much just went, especially at the beginning. So that's to be expected. Then there's a group of people who may then have applied a different threshold of what they think was a reasonable reason to attend the A&E department. We know that there might be people, or there always have been people, and might continue to be people, that may use the ED for the reasons when in fact self-care may have been more appropriate. And so I think people thought, stay away from the hospital, either protect the NHS or protect themselves, worrying about catching COVID. So there was an application of a different threshold that individuals may have used to consider. And then the third group, which is probably the more concerning, may be that group of people who should have contacted emergency services or accessed urgent and emergency care, but maybe didn't want to bother the doctors, they didn't want to be a burden, or they were more worried about catching COVID than the reason for the emergency, such as chest pain, etc. So we need to understand what's the reason, and what maybe we want the new normal to be. So we don't want people who should access services to not access it, nor do we want people who maybe need to reassess the threshold for use of those services. Does that sufficiently answer your question? Thank you.
Yeah, I think we didn't hear you, Rob, but I think you definitely did in detail answer Rob's question, and I think some of the issues you raised actually are mirrored in general practice as well. That the consultation rates have gone down, and some of them, have been for the reasons exactly as you've described for the ED department, including some concern that the people who needed to access services haven't, and what the consequences of that is. Now, I will take any other questions, but in terms of timing, we're pretty much on track. Kath, I don't know whether you wanted to make any other comment on that question that we had at the beginning.
Yes, please. I think Tim or Chris is going to put a slide up setting out just to remind everybody what that question was, and it relates to access to interpreters, particularly British Sign Language interpreters, and the difficulties that were being experienced in accessing that, and suggesting it was always challenging, but maybe even more so during the COVID situation, and about how the CCG will work with specialist organisations for people with hearing challenges, and particularly those in need of British Sign Language interpreters. So could you go on to the next slide? Thank you. So the slide sets out our response, which we will be publishing and sharing, and essentially the DA Languages, which is the provider of the interpretation service, has continued to provide the full access to interpreting and translation services, which includes British Sign Language. And they've been made available for online consultations to all GP practices, but also all dental practices that have been operating across Norfolk and Waveney, and are in support of all of the changes that have been made in the way that primary care services are being delivered and able to be accessed by patients throughout COVID. The CCG has written to all primary care, GP practices and dental practices to remind them, because sometimes maybe it is about making sure it's at the forefront of people's mind to use the interpretation services. But there may be times when interpreters may need to physically access practice, particularly if a patient requires a physical examination, etc. And those that do attend, whether it be the GP practices or the dental practices, will also be adhering to all of the required infection prevention control guidances and practices, and will be reminded by all of the individual organisations that they're visiting. And at the bottom paragraph makes reference to virtual services are available on demand for non-English speaking patients and for non-speaking patients in the deaf community. But what we've also done is contacted the walk-in centre in Norwich to remind them and encourage them to use these services for people when they walk in where it's required. I'll stop there then. Thank you. I think you're on mute, Anoop.
Yeah, no, thanks for that reminder. Thanks for that. Any questions or comments? Judith, have you got your hands up?
Add to that something that came through very strongly from the Healthwatch survey that ran for 10 weeks through the pandemic initial period. One of the very strong messages that came out, the accessibility to information for people with various impairments of hearing and vision was lacking. So people told us that they couldn't get hold of easy read documents, braille documents, and sign language. So, and the other thing just to add is that the issue with the contract with DA Language was something that was problematic earlier, but even pre-COVID. And I know it's something that Fiona Thiedem has been checking on, reporting on for NHS England, but we've also got it in our be tracking it because we're still not getting good feedback from people from the deaf community saying that contract is working terribly well, regardless of COVID. So I think it needs in the future, if that's possible to.
Absolutely. We'll take that away and look at it further.
Yeah, thanks very much for that contribution, Judith. Okay, thanks everybody. Let's move on then to next item, which I think is 11 over the page, and it's to receive annual reports. Obviously, we are a new organisation, a single CCG that started in April, but there were 5 CCGs that merged, and part of the governance of CCGs is that each organisation has to produce an annual report and accounts. So this is the forum for us to receive the reports of the 5 former CCGs. Melanie, do you want to introduce that item?
Yes, thank you, Chair. So I'd just like to present to you the 5 annual reports and accounts for the 5 former Norfolk and Waveney CCGs. The link on the paper takes you to the website with the full details of all the annual reports and accounts for that period. And that's all I was going to say, and just wanted to open it up to comments from other board members who may like to comment further around the individual CCG annual reports.
Okay. And obviously within the governing body, we have got members who have worked in the previous CCG. So are there any comments from any of the governing body, but particularly members of the previous CCGs that might want to comment on the annual reports from their former organisations? Oh, John? Yep. John Webster, yeah.
Happy to, Chair, just in terms of the outcome for West Norfolk. I know Howard's also part of the meeting. He was the CFO at West Norfolk for for part of that year. I mean, I think from my perspective, it was just a really pleasing turnaround in financial performance and performance in relation to quality and operational issues within West Norfolk. The CCG at the time had gone through a period of financial turnaround. I think everyone battened down the hatches, and it was a really fantastic effort, I think, to turn around performance in West Norfolk. So really pleasing to see that we were able to contribute towards the starting point for the new CCG as well. And thanks for the offer to comment as well. Appreciate it, Chair. Thank you.
Okay, thank you. Any other comments? No. Well, I'm gonna declare an interest that I was chair of North Norfolk CCG, so I can comment on North Norfolk. And I wanted to say that in the last year that the CCG did stick to its even though a lot of the work was on merger, it took very seriously its responsibilities and did meet its responsibilities and including financially. And it's proud for me to be chairing that organisation until its end. In particular, I think one of the values of CCGs previously, including my own in North Norfolk, was the contribution of practices. And I think I can talk on behalf of the other CCGs as well. And one of the things that we've tried to maintain within the new merged CCG is that clinical engagement. And I think what comes across really powerfully within those annual reports is the contribution and involvement of particularly primary care and GP practices, who are the constituent organisations within all CCGs, including our new one. And I think one of the things that the messages we had very powerfully from the previous CCGs, that they wanted that locality focus, that they wanted particularly practice engagement, and we're very focused within the new CCGs to make sure that continues, particularly in relation to our primary care networks, which I think are the future of local practice involvement within healthcare. So, yep, Arden, that inspired you to say something about Great Yarmouth? You'll have to unmute.
Sorry, yeah. Well, I felt I had to just draw attention to a couple of things that we're particularly proud of from Yarmouth and Waveney. And that was around the clinical engagement that led to a massive reduction in opiate prescribing, which was due down to all the hard work of all of the practices. We had a legacy of very high opiate prescribing across the board, and actually a vast amount of work was done with clinical engagement across the board, and which led to very successful reduction. And the other thing, of course, that we're very proud of is the pod, which has led to reduction and consolidation of repeat prescribing and addressing some of the issues around polypharmacy. And so both of those things, just like to say, Yarmouth and Waveney, we're very proud of. Thank you.
Great, thank you. Okay, great. Well, look, thanks for that. We're running to time, and we'll move then to the. So we're asked to receive those. We don't have to approve them. We're asked to receive those reports, so we don't need to vote on that.
That's so just to receive those, Chair, in public.
Yeah. Okay. Great. Thanks, Karen, for setting me on the straight and narrow for that one. Oh, I've got Rob. Your hands I've seen. Yep.
Thank you, Chair. I would like to record appreciation again to all of the staff who have had a hand in producing those reports. They are very, very comprehensive documents. They were put together in accordance with the original timetable for completing them, and in very, very difficult circumstances, as we know. So I think we do need to record our appreciation as governing body members for all of the input that everybody had to all of those 5 reports. Thank you.
Yeah, no, great. Thanks, Rob. I'm really pleased that you mentioned that. I should have said that as well myself. Great. Okay. Well, thank you, everybody. So let's move on to item 12, and I'd like to invite Mark Lim to the meeting as well. To talk about us approving some clinical threshold policies and amendments to current policy. So Mark, do you want to talk us through that?
Thank you, Chair. I'm Mark Lim. I'm Associate Director of Plan Care and Cancer for the Clinical Commissioning Group. Just for those who are perhaps watching this for the first time, a clinical threshold policies refers to essentially policies for referring mainly to hospitals for things like high-cost devices or surgery. And all CCGs in East England have sort of similar policies. And the way it's managed in Norfolk and Waveney is that there's a core group of myself and 4 other doctors and various support officers who look more carefully at the drafting of the policies and the wording, and then we take the lead in consulting with a wider group of clinicians, both from hospital community trusts, other GPs, in order to get the wording to make sure it's understandable, follows best practice, and ensures that most appropriate patients get seen by hospitals. So over the period of the last few years, we've accumulated a fair number of policies. And so all the policies that you are seeing today are those for which there's an existing policy, but there are some revisions. And I would like to highlight 2 in particular, which I think are the most substantive. The first one is in relation to the hemorrhoid policy. So we had some feedback from the surgeons that there were certain patients who previously under the old policy had to wait a certain amount of time trying non-surgical treatments, which I won't describe on the YouTube video, to actually try those things prior to actually having surgery. The surgeons have given us some more detailed guidance about the certain kinds of hemorrhoids, which, regardless of what you try, will definitely need to be operated on. And so we've changed the wording of the policy to reflect their experiences with the previous policy. The second major area relates to the functional electrical stimulation policy for foot drop. So that's essentially like a band which goes around the leg and helps to essentially sort of stimulate the leg and essentially strengthen the muscles and stop the foot dropping onto the floor. So previously that was something you had to apply on an individual funding basis for. But we've had a number of applications. So we've reviewed which instances these treatments have been successful and not successful, and worked with Norfolk Community Health and Care and the East Coast Community Health Care to come up with a policy which we think reflects our experience of those applications. And so hopefully those patients will now be able to access that funding without having to undertake the paperwork to have an individual funding request. So I'll leave it there and I'll ask members of comment. Thank you.
Okay, so any somebody's on mute, I think. So are there any questions or comments before we ask you to approve it? Claire.
Thank you, Chair, and thank you, Mark, for all the work that's gone into these. Can I just the foot drop policy? I'm going to declare a conflict of interest. I lived with one of those for a long time, and I'm delighted to see that people actually would have access to support for that without having to go through the individual funding request panel. I was lucky; mine recovered before I got that far. The other one I wanted just to ask a question about was with regard to the Achilles tendinopathy pathway, just with reference to the impact on occupation and whether that was something we maybe needed to change the wording about. It was just a suggestion. So I have to say, I haven't looked into the evidence on that in any great detail, but I'm aware that it's a condition that commonly impacts a person's ability to work. Whether that would automatically therefore constitute a significant problem that would warrant referral, or whether it might be useful to include that in there, just for clarification around the policy.
Thanks, Claire. I appreciate that. So the wording around the regional policy was actually mainly guided to a large extent by the secondary care consultants, because they wanted to see patients for which they felt they could do something positive for. I think it's fair to say we did not explicitly consider occupational health impacts in our discussions. I'm fairly sure we didn't, and we have in some of the other policies, for example, relating to hernias, explicitly considered that. So I think I would be happy to go back through the group and just to review that policy again and get feedback from secondary care. Would occupational health reasons be a reasonable reason? It may well be that they come back to say, well, even if it's not possible to do something for those particular patients, and even if it is influencing the occupation, but I think we should check that before signing that off.
Okay. And any other questions or comments on that or the other policies you're asked to approve changes to? No, and I mean, just as an explanation, as it says in the heading sheet, it has gone through clinical review through the policy group, and governing body members should be aware that that it has come to the clinical executive. So the clinicians on the governing body meet regularly, and these amendments, although they have to be formally approved by the governing body, you have got some assurance that they have been discussed by the clinicians on the governing body already, because we do appreciate that it might be difficult for some of these detailed policies for lay members particularly to be sort of knowledgeable on the clinical side of things. So I'm happy to take any questions or comments, but if not, can I ask you then to approve those policies, bearing in mind that additional comment from Claire that the group will look again at the tendinopathy in relation to occupation. Can I ask you to approve? Yep. Okay. So that's unanimous. Okay. Great. Thank you. So the next item is 13, and Karen is going to go through the governing body assurance framework and the risk management framework for the CCG.
Thank you, Chair. Thank you. So the governing body assurance framework is here for approval. The framework itself sets out how we propose to work on our assurance and our risk ratings going forward. So it sets out quite a clear process. I can assure the governing body that this has been gone through in quite some detail, both at the executive management team of the directors and also the audit committee, and their changes applied to that. So it's here today for approval. We've also set out for your information a template board paper so you can see how that might look going forward, and also a sample of the template of the governing body assurance framework, so you can also see what that looks like. So it's here for approval. Just to say, if it is approved today, we are working now behind the scenes to get the risk work undertaken. This involves getting risk registers complied at all the different directorate levels, and in some cases sub-directorate levels, and then feeding them up through an organisational register and a governing body assurance framework, so that we can be assured as a management team that you are seeing what are the key risks for the organisation at the governing body. And we anticipate having that work completed in September, so you'll be seeing that at your September governing body. So I don't propose to go through in any more detail. I'm happy to take questions on the paper, but it's here really for your approval of the framework. Thank you.
Okay, so we'll take any questions or comments before we approve. I don't know, from our audit chair, I don't know whether you want to make any comments on that, or anybody?
No detailed comments from me, thank you, Chair. We will learn as we go here, so we'll reflect on what we see and take account of what we're finding. Thank you.
Okay, great, thank you. Okay, well, in that case, can I ask you then to approve the draft risk management strategy and framework as presented to you? Yeah, okay, thank you. I've seen nods from everybody, so that's unanimous, thank you. So we'll move on to then next section 14, which is the finance report. And Jason Hollidge, acting as John Ingham's deputy, is going to report on the finance report. Jason.
Yes, thanks, Chair. This report is brought to governing body to note. It reflects the year-to-date month 3 June position. To give a bit of context, the NHS finds itself in an unprecedented operational but financial situation as well. The national planning framework and financial framework has been completely revised, and the original plans from the start of the year have been replaced by revised guidance for the period to April to July, which requires organisations to break even. We're expecting further guidance is anticipated by the end of this week for the August to March period, but it's anticipated that the August and September months will reflect those the guidance that we've received for months 1 to 4, and the September onwards period will be under a new regime. However, we haven't had the details of that new regime to date, but we're expecting that this week. Key year-to-date headlines are the CCG is reporting a 15.5 million shortfall against the revised allocation. The key component parts of this are 6.1 million relating to the June COVID claims. The April and May claims have been received. 3.7 million relating to the mental health investment standard, which wasn't included in the month 1 to 4 allocations, and has been acknowledged by NHSEI as an additional top-up that will be received by the CCG. And it's been confirmed that the full year values for the mental health investment standard will be applied in line with the national mental health priorities. So that's a good thing. The remaining 5.7 million relates to differences which have arisen due to the change in the methodology of the allocation. So the methodology has been based upon the month 11 year-to-date 1920 position. And there are various things that are inherent to that position, which mean that our allocation for the first 4 months is different to what we anticipated. And we're liaising with NHSE and I on these items closely, and there has in fact been a month 1 to 3 bridge analysis that we've submitted to NHSE regional team, who are taking it up to the national team, and it's being consolidated at a national level. In reference to the COVID costs, to date, the CCG has claimed 15.7 million, of which 9.6 million has been received already. That leaves the 6.1 million outstanding, which I referred to earlier. In addition, the paper contains 13 key financial risks. These can broadly be grouped into 3 categories, which relate to the achievement of the plan and the break-even position, the management of demand and capacity in our providers, and also the delivery of the future efficiency once we get back to normal, whatever normal will look like post-COVID. All of these items were discussed at the Finance Committee on the 21st of July, and we can open up for questions. Thank you.
Okay, thank you. Thanks for that, Jason. Hein, did you want to comment as chair of the Finance Committee?
Yes, please, Chair. First of all, I would like to recognize the huge work that's going on in capturing the COVID-19 related costs that may be taken for granted, but there's a lot of work going on behind the scenes, and also the management team is clear line of sight and supports that effort. As you can see from the papers, it already adds up to a significant amount of money after several months, and that will increase further. And you can be sure we will be audited upon it. So I'm also confident by the transparency of the process. As Jason has mentioned, we have followed this closely in the Finance Committee, and maybe it's apt after we just approved the draft risk management policy that we also make active use of what you can see on the last page of the pre-read and really discussing the key risks that we see. And I think Jason has reflected well on them. It's also encouraging to see that we should get more clarity on the financial regime later this week for the coming months. I want to leave it at that, Chair.
Great, thank you for that. Any comments from the rest of the governing body or questions on the month 3 finance report?
There's Mark Anoop waiting to come in.
Mark, yep. Mark Jeffries.
Thanks, Anoop. Yeah, just a question for you, Jason. On page 3 of the report itself, you talk about the overspends and top-up payments and notification that you're awaiting. Is that what you're expecting to be in the August guidance that you referred to?
Yes, in part. So we've had confirmation that we'll receive the full details of the Mental Health Investment Standard, but we will receive the framework regarding the other items. So we won't actually receive the values this week, but we will receive the framework those items will be based upon.
Thank you.
Okay, thank you. Any other questions or comments? No, okay, great. So we're asked to receive that report. That's not for approval. So agenda item 15 is to review the letter for the previous 5 CCGs from our external auditors. And I've got Jason and Rob against that item. So who's going to, Jason, is that yourself?
Yeah, I'm happy to kick that off. Yeah, thanks. Yeah, so as in line with item 11, when we received the annual report and accounts, this is the formal communication in public of the annual audit letters from our external auditors, BDO. These represent the detailed reports that have been to both Finance Committee and the previous governing body in private. So they were discussed at the Audit Committee on the 21st of July, and hand over to Rob as chair of that committee for anything else he wants to discuss further.
Okay, thank you. Rob, did you want to add anything?
Nothing more really to add, Chair. Jason's covered it. They're very concise summaries of the external audit work. The very good news is that all of the financial statements received unqualified audit opinions. And we will debrief with the auditors to learn any lessons from this year's process and take that into the current year process. But again, it's great credit to the team in the finance department again for putting the accounts together and the quality of the output.
Okay, great. Well, thanks for that report. So to my reckoning, we're now on item 16, which is to receive a verbal report from the Audit Committee, and that's yourself, Rob, as chair of the committee.
Okay, thank you very much indeed, Chair. Very, very briefly, Chair, we had a meeting last week. You will see the formal report from that meeting shortly. We discussed the assurance framework that we've already approved this afternoon. We discussed the external audit letters that we have just discussed. The other updates that we had were in relation to the internal audit plan for this year, and we approved that plan. And we had an update on the counter fraud work that has been undertaken by the counter fraud specialist.
Great, thank you very much. Any questions for Rob? No? Okay. Well, I think we've done pretty well with timings. So thank you everybody for sticking to your time briefing. So we've come to the end of the planned business. Are there any other items of business not already on the agenda? No? Okay. Well, it leaves me to conclude the meeting then. Just thank you everybody for attending, particularly for the team for organising the meeting. Again, it's not been easy, but I think we've tried to do the best to kind of meet in public, and it's been streamed live today. I think the next meeting, we have to assume that in the coming months that we will be working remotely. So any suggestions on how we could perhaps change things to make it more accessible to the public, because we are publicly accountable, would be welcome. I think we need to be open to suggestions about working in new ways to involve our public, and particularly I think Mark, yourself as our lead for public and patient involvement, if you've got any suggestions as to how we run these meetings to make them more accessible, I'd be very open to suggestions. Finally, I'd just like to thank particularly Tim Curtis and Chris Williams for helping run this behind the scenes, helping me to chair the meeting. And in particular, I wanted to thank Tim Curtis, our Director of Communications and Engagement. It's actually his last governing body meeting that he'll be supporting, because he'll be leaving the organisation. I think he's leaving the NHS after many years. I just wanted to thank Tim personally and on behalf of the governing body for the support that he's given, and not just for this CCG that's only a few months old, but actually for a number of predecessor organisations. He's been working for the NHS for I can't remember. Was it 25 years, Tim?
No, only 11. But thank you, Chair. Very kind words.
Okay, you're very welcome. So thanks again to Tim. So I'll close the meeting. The next meeting will be on the 29th of September, venue to be agreed. So thank you for coming. And if you can switch your